Thank you, Dr. Hardik. It's a, again, cordial invitation from a heritage city of India, Pune, and I'm delighted to be with you all this morning with a very noble concept of bringing some molecule known to you for almost 65, 70 years to extrapolate the effect in diabetes. Before I start, I must thank the team IDEC 18 for hosting the prestigious event year after year, and the whole task force, mainly Sanjay and Neeta, for inviting me to this session and doing good academics for all of you. Reviewing some of your knowledge in the history, you'll be surprised to know this molecule is approved way back in 1955. It was predominantly used in rheumatoid arthritis and lupus, but it's a very old molecule of almost 65 to 70 years, and also listed in WHO Essential List of Medicines. An Indian recommendation by CDSCO comes in 2001 for RA, 6 for PMLE, 8 for lupus, and 14 for diabetes. The addition of hydroxy group, this is the hydroxyl group, gives the additional advantage of limiting the ability of hydroxychloroquine to cross the blood-retinal barrier. Clearance of the drug from the retinal pigment cells is faster as compared to chloroquine and makes it more suitable for chronic disease, because chloroquine is used for 4 to 5 days in malaria. Here we are using for years together, and this advantages I'll show you how less is the retinal complications. So we'll see the mechanism of action, how inhibition of the insulin degradation takes place, reduction in inflammation takes place, insulin sensitivity improves, and the beta cell preservation takes place. The first to start with the inactivation of insulin degrading enzymes. Reviewing your knowledge of the insulin degradation pathway, you know the half-life of insulin is 4 to 6 minutes, and the enzymes are protease, the glutathione insulin transhydrogenase, and lysosomal protease. When the insulin binds to the receptor on the shell, it is internalized. The dissociation from its receptor takes place, which comes to the cell, and this degradation by the enzymes takes place. After that, the receptor recycled to the cell surface. This is in a nutshell the degradation pathway. And when the drug comes, it comes inside the cell, it comes inside the vacuoles, molecules, and it acidifies, alkalization takes place, and the acidification is neutralized, resulting in inactivation of the enzymes. Then the less insulin is degraded and insulin is released as it is ready to act. To review, you can see the previous mechanism where the degradation enzymes were working in an acidic environment, and here they have been alkalinized, resulting in inactivation of degradation enzymes. Anti-inflammatory action. Way back, since use in the Sjogren syndrome, we have seen the effect of hydroxychloroquine in reducing hsCRP as well as interleukin 6. Gradually, when you use for 6 months, 12 months and onwards, that shows the anti-inflammatory action, and you have heard very well the concept of inflammation from Dr. Bhabna. It improves the insulin sensitivity. You can see the latest publications, both beta cell function and insulin sensitivity in non-diabetic or pre-diabetic individuals has been noted, and these metabolic effects explain the hydroxychloroquine treated patient is associated with a low risk of type 2 diabetes. Many patients treated for rheumatoid arthritis or lupus have an immunity for the development of the diabetes, and people have noted patients of having diabetes as well as rheumatoid arthritis, when added with this drug, has a decreased requirement of the insulin and the interventions. The plasma adiponectin is clearly increased with this drug. There are studies showing from different time in different indications. It preserves the islet structure and increases the beta cell mass. You can see this, that not only it decreases the pancreatic levels of interleukin 1 beta, TNF alpha and TGF beta 1, preserves the islet of Langerhans, significant increase of beta cell mass which is statistically significant, and the islet of Langerhans proliferation and neogenesis. You can see this picture of a diabetic before and after treatment with the hydroxychloroquine. This is of course from the rat experiment, and you can see the enhancement of the islets, enhancement of the beta cells and decreasing the unduly enhanced alpha cell in a diabetic patient. So reviewing your knowledge about the clinical efficacy, in 1990 it was approved for add-on to insulin or sulfonylurea, 2002 for add-on to sulfonylureas, 14 sulfonylurea and metformin, and the latest publication in 17 shows the add-on to sulfonylurea and metformin and comparison with the teneligliptin. I'll show you all the studies. Add-on to insulin clearly shows there is insulin dose is decreased almost by 24 units per day, and A1C is reduced by 3.3%. So only addition of hydroxychloroquine has averaged 30% reduction of the insulin dose. Sulfonylurea additions, you can see the adding decreases the A1C levels by 3.3, and in type 2 diabetes, the mean A1C in 6 months, 9 months and 12 months is steadily decreased in excess of placebo. The metformin and sulfonylurea, the first Indian study in 2014 showed, this was the protocol, there is a clear reduction from the baseline, where you can see the fasting plasma glucose as well as the A1C reduction was at par with the pioglitazone, and the postprandial plasma glucose was much better than the pioglitazone in a week 12 and week 24 study. So it decreased the lipid parameters as well. If you ask for the pleiotropic effects, it decreased the total cholesterol, LDL cholesterol and the triglyceride, and also the weight loss was 1.08 kilos, and the pioglitazone group had an increase of 0.73 kg, which shows the difference. So basing on these data, the DCGI approved it in type 2 diabetes in 2014 as an adjunct to the diet and exercise, and it has been since there in the protocol or the guideline, but unfortunately very less popular because the awareness is not there. You see the effect of hydroxychloroquine in the diabetes mellitus, unresponsive to more than 2 oral antidiabetic agents. The mean reduction of A1C in metformin glimepiride combination and metformin glimepiride and teneligliptin combination, you can see the effect is much better in this hydroxychloroquine combination. This is a study from 2017 where the patients who achieved the target A1C had almost 20% more than that of the teneligliptin combinations. And with this all data, let us see some CV protection data which shows the mechanism by which the hydroxychloroquine may mediate its CV effects. In rheumatoid arthritis, it shows 72% decrease in the risk of cardiovascular diseases, and the retrospective incidental RA cohort shows a clear-cut advantage in this group. And if you go to the rheumatologist, they'll also show you the data how this drug effectively controls the inflammation, decreases the arthritis associated with diseases like rheumatoid, and eventually decreases in the major adverse cardiovascular outcomes. So these are the Oxy trial, ongoing trial of CV events in the Helsinki University, and the outcome is yet to come. And so many global trials starting from the Washington University School of Medicine to the University of Pittsburgh and the Charles Drew University of Medical Sciences. They are studying this drug as a novel molecule in type 2 diabetes. Regarding the retinopathy and hydroxychloroquine, we have a lot of confusion because routinely the rheumatologist prescribe a perimetry examination of visual fields, but if you see the duration of study and the number of patients developing the retinopathy, it is very low, almost 0.08% incidence in a cohort of more than 1,000 patients, and in a only 0.5% after 8.7 years of the usage. That's after a long use. So frequency of the future monitoring based upon the patient's classification of low or high risk. The Association of Ophthalmologists, America, approves it should be monitored only after more than 5 years of treatment of hydroxychloroquine and when the dose is more than 6.5 milligram per kg per day. If there is a significant renal or hepatic disease, pre-existing musculopathy due to other etiology, elderly, obese, and cumulative hydroxychloroquine consumption of 1000 gram, then only you need a monitoring of total ophthalmological side effects including perimetry and retinal changes. This American Association of Ophthalmologists 16 recommendations show a baseline screening, a fundus examination within the first year, and visual fields if maculopathy is present, and annual screening being after 5 years of use, what I have shown, and annual screening in presence of major risk factors. The recommended screening are automated visual fields and SDR OCT. The last complication which has been raised regarding the drug is hyperpigmentation. A retrospective study comparing SLE patients shows skin pigmentation appears after 6.1 year of hydroxychloroquine treatment, and incidence of hydroxychloroquine induced pigmentation reported as 7.3% with majority of cases secondary to ecchymosis or bruising. So this is also a not major concern which has been raised, and rather in lupus and other indications for pigmentation we prefer this molecule for the treatment. A 2018 study, I thought that I'll quote this, which shows the HSCRP is low, which is statistically significant, A1C decrease, fasting decrease, postprandial decrease, and total daily dose requirement of the insulin decreased. So it reduces the inflammatory markers, and 28% reduction in mean total daily insulin dose within 6 months with a very good control of fasting, postprandial, and as well as the A1C. But one thing you have to remember, around 15% of the patients to this drug remain as non-responders. So if you are using this drug and not getting any good response, maybe genetically they are non-responders to the hydroxychloroquine and you have to drop them from the trial. Every patient, we don't expect the result. This is again a study comparing the effect of hydroxychloroquine and vildagliptin. Previously shown with metformin, sulfonylurea, insulin, as well as teneligliptin. This is, the study is on, this is 2018 study, the result has not come. The hydroxychloroquine with vildagliptin with glycemic effects, A1C, inadequately controlled with metformin and glimepiride therapy, where the vildagliptin and the hydroxychloroquine are compared head to head. Before I conclude, the RSSDI clinical practice recommendation for management of type 2 diabetes 2017. Recently, we released this 2017 guideline. You know, this is the only Indian guideline which exists since 2015, and many who are in this convention were part of this guideline, and also present last 6th of May, where this guideline was released in Delhi by a team of guests, and the guideline recommends the glucose control targets are no longer being achieved, insulin or add a third oral agent. This is the third line therapy. And options for third oral agent includes the alpha glucosidase inhibitors, DPP-4 inhibitors, or SGLT2 inhibitors, thiazolidine, depending on the second line agent you have used. You know, we are starting with metformin, not adequately controlled. We are adding either of these drugs in the second line, and when you come to third line, any of this agent in the Indian patients which has not been added can be thought of, so also hydroxychloroquine. Because from July 14, the hydroxychloroquine has been approved by DCGI as an adjunct to diet and exercise to improve glycemic control, and on sulfonylurea and metformin combination. So we can consider this as a third line therapy when we fail in lifestyle, fail in metformin, fail in second drug, as a third drug, along with this group of alpha glucosidase inhibitors, DPP-4 inhibitors, SGLT2 inhibitors, the glitazones. We can add hydroxychloroquine just to keep it in your mind, so that when you face the next patient, and patient insists that, sir, I don't want insulin. So either insulin or a third oral agent. Start insulin or add a third oral agent, and adding a third oral agent is much preferred by our Indian patients, that all of you know. This is a picture from Delhi program. Dr. Jitendra Singh was kind enough to release the 17 guideline, where it was the part, and RSSDI endorses use of hydroxychloroquine as a third line agent when the control is not adequate with lifestyle and the first two drugs. This is again the link symposium which was following the program just this month, in the beginning of this month. So to conclude, ladies and gentlemen, the diabetes is ever increasing. With a high prevalence, is an important public health problem with long-term complications. And I understand all of you are into the diabetes practice and facing the music day in and day out, the high A1C, poor control, patient not wanting injectables, not wanting insulin, and more drugs. When you give metformin, give sulfonylurea, give gliptins, give SGLT2, exhausted, till fourth drug, fifth drug is demanded. And only in India, patients insist that, and the physicians prefer that. In that situation, we have a new drug in diabetes here, which is not new in the real sense. It's there in the clinical armamentarium since 1955 and has been endorsed by world authorities like the WHO as well as the American Association of Ophthalmologists and many other world bodies regarding the safety and efficacy. And its efficacy for control of glycemia and as well as the complications goes without saying, because many of the rheumatologist friends of mine have opined, अरे ये जो शुरू कर दिया तो देखा ग्लूकोज अपने आप कम जाता है, इंसुलिन डोज रिक्वायरमेंट कम जाता है. It's a very common finding in the Indian practice. And none of the newer drugs, maybe gliptins, maybe SGLT2 inhibitors, act on the core pathophysiology process of the beta cell dysfunction in diabetes, which this drug coincidentally works. And considering the anti-hypoglycemic potential, anti-inflammatory activity, and other pleiotropic effects, the hydroxychloroquine may emerge as a cost-effective therapeutic option for uncontrolled diabetes patients. And all the recommendations say that we need not monitor the complications before 5 years. So what do we think, that it can damage eye, it can damage kidney, it can do pigmentation? This is all just the market suspicions, and comfortably we can go for an affordable drug for our patient when the glycemic control is not adequate. And it has shown promising results in improving beta cell and has also shown CV risk reduction in the setting of rheumatoid arthritis and lupus. And I'm sure the same thing can be extrapolated here. So thank you for the time. Thank you for the attention. Before I end, just to answer my mentor, my guru, Dr. Arvind's query, that why he is sandwiched. That is because of the intimate relationship with the speaker 1 and speaker 3. And he has been a father of the diabetology in the country. So I put my regards for him and conclude my session. Thank you.
Thank you, Dr. Jayant Panda. Now the house is open for question and answers. So I invite Dr. Bhavna Sosale also. So you can ask a couple of questions because we have 5-10 minutes before we go to hall A for the keynote lectures. Can you please pass on mic?
The question come to you first.
Good morning, sir. I just...
Yeah, sir. Actually, sir, diabetes is a lifelong disease, but treatment, what you are choosing, maybe oral drugs, maybe insulin, is not for life. So time to time you are revising your prescription. So now the safety profile we have till 5 years, 6 years, 8 years like that. And time to time we have to monitor. Maybe patient has some symptoms and maybe after 10 years or 12 years, patient may be in need of insulin. So the plan is not for life. The disease is for life. So comfortably you can start and continue till 5 years, what data I show in the literature.
Yeah. Good morning, sir. I just want to ask you that whether we can add hydroxychloroquine to type 1 diabetes who are uncontrolled on insulin, who are having the maximum glucose variability and the doses are high. So are there any trials for type 1 diabetes for HCQ?
Yeah, this is a very valid question. Now,
because by the mechanism of action, it appears that it may be acting in the type 1 diabetes also. It is insulin independent action.
Anti-inflammatory action and the action for the beta cell protection and the islet of Langerhans applies to type 1 as well. But at present, the studies are on and there is no approval of this drug in type 1 diabetes.
Yeah, I think one of the mechanisms of action of hydroxychloroquine is to prevent insulin degradation. Now in type 1, the question arises, is there enough insulin at all inside? Is there anything there to prevent
I'm just saying it is adjuvant to the insulin, what we are giving, to decrease the dose of the insulin.
I would stay far, far away from that position at all. Unless it comes as an FDA approval and there is more than enough evidence, I would just stay wide away from that.
So are there any trials which is going accordingly?
Not to my awareness, no.
What about LADA? LADA, there is a gradual degradation of the beta cells. There can we try such a type 1 is definitely the beta cells are already like absent, I will say, destroyed totally. But what about LADA? Because that is very gradual and slow process.
Again, we don't have any evidence, but I would not want to take decisions like that clinically, and I wouldn't use it in anyone with LADA or type 1. Because these are individuals who have insulin deficiency and they're more prone to ketosis. So if we are not giving them insulin and we are trying alternate therapies just to please them, you're going to step into a very dangerous zone of having a lot of patients with problems and you're opening up yourself to lawsuits.
So we discussed about the long-term complication. So I tried this molecule in my 5 type 2 diabetes patient. Out of that, I withdrew in 3 patients because of severe gastritis. So that is a major hurdle I seen while using HCQs.
Yeah,
so because that hampers a lot.
Yeah, it has some GI intolerance, but you can control aiding a PPI or asking them the time of the drug, you can do that. Regarding that LADA, it's a adult type 1 diabetes. Right. And as Dr. Bhavna has rightly told, any situation where we have insulinopenia, because the major effect, we have different mechanism of action, anti-inflammatory and beta cell preservation, blah, blah, but the most important is the degradation enzymes. Right. And where it's an insulinopenic situation, we have to avoid this drug. And there, the insulin is always preferred. Anybody who is not tolerating this drug, GI symptom-wise, or the ophthalmological complication-wise, you can jolly well choose other drugs or drop. It's not that every patient you have to try. But as I told, a section of patient will not respond at all, even after addition. You have to choose them as genetically non-responders and you have to drop them.
In LADA, there is small amount of insulin secretion is there.
Yeah.
So, because this prevents the insulin
But
degradation.
it gradually goes down.
Goes down. Huh?
Yeah.
But can we prevent by adding such
Prevention of LADA?
beta cell destruction and all?
Not reported
Not
and not
reported,
expected also. Here, for now, let us limit this to type 2 diabetes.
diabetes, okay.
Yeah, and insulinopenic situations, better will not extrapolate this drug.
Okay. Thank you.
In non-proliferative diabetic patient, one is, and then will you start hydroxychloroquine?
In patients having retinopathy?
Yes.
NPDR?
Yes.
Don't start.
Yes.
My suggestion is patient is having a retinal complications already, maybe a non-proliferative diabetic retinopathy, please don't start because the drug has already existing retinal complications which can further worsen.
And most of the patient taking at least 3 anti-diabetics. Can you add as a fourth? Mostly patient don't want to take insulin.
Yeah. The international guidelines, they don't advocate for the fourth, but in India, we are going up to fifth, you know that.
Yes. Yes.
that's an extension of the use in the field, but when it's failing with 3 drugs, ideally is insulin, but if patient is very reluctant, stubborn, you can try with a drug of different mechanism of action.
Jayant, just a question.
Sir.
Yeah.
Sanjay.
Now you have 15% non-responders to
Yeah.
to HCQ. Can you point out any surrogate markers which suggest that these are the patients it's better to avoid, they won't respond? Is there some data?
Clinically, you cannot know.
Okay.
In our trials, we have seen a class of patients that don't respond at all. So no change. So we confirmed in a genetic study they are non-responders. But this is a research setting. Clinical setting, you cannot know who will respond, who will not respond.
In some studies, it was seen that based on the HSCRP level, when HSCRP was higher at baseline, those patients were responding, and those who had lower levels, those were the cases where you would see this situation of non-responders. So if we measure that in clinical practice, yes, maybe we would know if that is the reason why a patient is not responding. But even if HSCRP is high and patient doesn't respond, then we don't know. We'll have to try different therapies.
Yeah, she is right. Actually, because prime action is anti-inflammatory, HSCRP indicates the level of inflammation. Higher HSCRP, the chances of better response of the drug.
Thank you.
So what is the therapeutic dose, or it is working on 200 milligram also?
No, 200 milligram which is available in the market, that is for rheumatoid arthritis and SLE. Here it's 400 milligram.
No, but 200 milligram low dosage also can be working in diabetes.
Low
or
dose
control.
hydroxy, for diabetes management, the recommended dose is 400 milligram. So I think better you stick to the recommended doses, and even
Because there are a lot of some side effects are there, so that's why we can go ahead with some 200
you
milligram
cannot
adding
get
and
the
maybe getting
expected
some
result with the 200 milligram dose.
We'll have last question and then we end the session.
How common is the pigmentation side effect, and how long it takes? Means how many exposure of drug, dose dependency, duration of the drug,
Yeah.
and how do you handle it? Suppose a lady, diabetic lady, she gets pigmentation, she might blame us.
Yeah, I showed you that slide, the pigmentation one, that has been raised. This study where the skin pigmentation appeared after 6.1 years of hydroxychloroquine treatment. Can I have the projection? And incidence of hydroxychloroquine induced pigmentation reported as 7.3%, with majority of cases secondary to ecchymosis or bruising. After ecchymosis and bruising, they have a tendency for the pigmentation, not spontaneous. So this shows that it's not a major side effect, but the recommendation when you have this to discontinue the drug, not that you have any drugs to manage the situation.
Thank you, sir. With this, we end the sessions, and I thank all the speakers, Dr. S.R. Arvind, Dr. Bhavna, and Dr. Jayant Panda, and thank the wonderful audience.